Hello, and thank you for joining us for the virtual Healthy Minds, Healthy Bodies seminar, Enlarged Prostate, Understanding Your Treatment Options. Can you go ahead and advance the slide, please? Before we get started, I want to cover some quick rules of engagement as it relates to the event today. The presentation is being recorded. A link to the recording will be provided in a follow-up email. If you have questions, please use the Q&A area to submit it. These will be addressed at the end of the presentation. Most importantly, please bear with us if any technical issues are experienced. Also, your feedback regarding today's presentation is important. A link to a survey will be provided in the chat area. If you can please take a moment to complete that at the end. Go ahead and advance the slide. Thank you. Today's presenter is Dr. Laciak with Samaritan Urology. Assisting with questions is physician assistant Jordan Johnson. It is now my pleasure to turn this over to Dr. Laciak.
Thank you all for joining for today's virtual seminar. My name is Dr. Robert Laciak. I'm a urologist here at Samaritan Urology. I've been practicing in Corvallis for approximately 10 years now. And we'll talk today about an enlarged prostate, diagnosis, as well as treatment options. So the agenda is to discuss what BPH, or benign prostatic hypertrophy or hyperplasia, is, how it's diagnosed, and the treatments that are available for you. We'll start with an overview of the prostate. The prostate's a walnut-shaped gland at the base of the male bladder. It surrounds the urethra, and it produces fluid that transports sperm through ejaculation. Now, the prostate grows to its normal size in your teenage years, but then it begins to grow again around age 50, and that's where the troubles start to happen for most men. We'll discuss a couple of the common prostate conditions that men deal with and are seen through our office. Prostatitis is a swelling or inflammation of the prostate. Prostate cancer is a very common cancer among men and typically slow growing. And the enlarged prostate, which is the subject of the talk today, is the enlargement of the prostate gland. Now, each of these conditions affects the prostate differently, and having one does not mean you'll have another. So an enlarged prostate and the symptoms associated affect nearly 40 million men each year in the United States. By age 60, 70% of men will have enlarged prostates and symptoms associated with this. And by age 80, nearly 90% of men will be affected by an enlarged prostate, as well as symptoms. So technically, what is BPH? BPH is benign prostatic hyperplasia. It's the clinical term for an enlarged prostate. This is the non-cancerous growth and enlargement of the prostate. It's not an indication of prostate cancer. And PSA, which stands for prostate-specific antigen, which is used as a screening test for prostate cancer, rises both with BPH and prostate cancer. So PSA alone cannot tell you which issue you're actually experiencing. So normal versus an enlarged prostate. The picture on the left side of the screen shows a normal prostate. And I want to point out there's an open channel here through the urethra because the prostate has not started blocking this up. The bladder is nice and normal and not thickened. It's smooth on the inside. It doesn't have to work very hard. On the right-hand side, you start to see what an enlarged prostate entails. As it grows, it puts pressure on the urethra. This pressure translates into the bladder working harder and causing urinary problems. In general, though, the size of the prostate does not correlate with the severity of symptoms. And what do I mean by that? It means that a patient with an enlarged prostate, possibly 40 or 50 grams, can have similar symptoms to a patient with a prostate twice that size. That's 80 or 100 grams. Similarly, a patient with a very small prostate can also have symptoms because their small prostate, in fact, is growing at a smaller rate, but still blocking this channel up sufficiently. This is another picture representation of a normal bladder versus an enlarged prostate causing bladder issues and deterioration. And you can start to see pictures of an enlarged bladder wall here and the trabeculations. These are those ridges in the bladder that happen from bladder damage over time. These are actual pictures now of, on the left side, a nice normal bladder, nice and smooth, some blood vessels in there. As the bladder worsens and the walls thicken of the bladder, you start to get these trabeculations. These are ridges in the bladder. And this is a sign that the bladder has been working too hard. And this is not for the 6 months that you've been having worsening symptoms. This is for the 6 years before those symptoms really started that things have been happening for. And then on the right-hand side, this is what I like to refer to as a sort of Swiss cheese bladder, a whole bunch of holes in them in the bladder. And this is from a bladder that's permanently damaged. And when I say permanently damaged, what I mean is patients that have their prostate fixed by opening up their channel that initially are seen with these trabeculations, these ridges and these holes. These are called diverticuli, by the way. If you look in their bladders 10 years later, they'll still have these because they never go away. They might shrink a little bit, but they never permanently go away. And this is the reason why it happens. So this is a normal prostate picture, and you see a nice open channel. This bladder doesn't have to work very hard. You have to urinate. It pushes the urine out of the bladder and through this nice open hole. As the prostate enlarges, you can start to see the ridges of and the edges of the prostate get closer in the urethra and start to block things off. And then for a significantly enlarged prostate, you see this blockage that happens, and the sides of the prostate, literally they smush up against each other. And this is what causes guys to really start to have problems with their urination. So what are the symptoms we're looking at? So we're looking for that weak stream. That typically happens when you're in your 40s or 50s. And then the thing that brings most men into our office is those other symptoms that happen 5, 10, 15 years later. But it all started with that weak stream from the blockage. But then you develop frequent urination. You develop an urge to urinate, multiple trips to the bathroom at night. It may be difficult or painful to urinate because you're having to strain so hard. You don't feel like you empty your bladder completely, or you have this stopping and starting, almost a Morse code of urination as you pee. Short bursts, longer bursts, short bursts. Now you can have all of these symptoms, or you can have a few of these symptoms. And ultimately affects your quality of life. You avoid travel. It interrupts your leisurely activities. You can't do that round of golf. You can't sit through that movie. You have to always know where the bathroom is on road trips, or know when the next rest stop is going to be. Or maybe you can't even make it to the rest stop and you have to pull on the side of the road. You start using bathroom stalls instead of urinals because it takes so long to get started to urinate. Or you dribble and you'll get it on your shoes, and so you decide, I might as well just sit down. And obviously this disrupts your sleeping patterns. Nearly half of men in the US with BPH, their symptoms get so severe that it affects your lifestyle and you eventually start to seek treatment. So when you come into our office with these symptoms, how do we diagnose enlarged prostates? So we do a medical history asking about your symptoms and the rest of your medical history that could affect, sleep apnea with getting up at night, medications that you could be on, Lasix or other diuretics that can make you urinate more. We do a physical exam that could include a bladder scan to see how much urine you're retaining in your bladder. We'll do a digital rectal exam to estimate the prostate size, the texture, asymmetry, any hard nodules that could be concerning for something like prostate cancer. We'll check your symptoms, which we'll use the AUA symptom score to find out how much of a bother this is to you. Now, the AUA symptom score is the International Prostate Symptom Score. It was developed and used by the American Urological Association throughout the country, looking at all the symptoms that I mentioned earlier. So we ask you about your frequency and your urgency, and we add up your score. A score from 0 to 7 are mild symptoms, 8 to 19 are moderate, and 20 to 35 are severe symptoms. And then we also ask how your quality of life is. Are you pleased with your symptoms? Typically not if you're coming in to a urology office for these, or are you miserable, which would be a 6. This is pretty small type font, but this is our AUA symptom score. Very easy one-sheet paper that you fill out. It takes about 5 to maybe 10 minutes at the most to fill out your symptom score. We use this to assess how bad your symptoms are and also how you respond to treatment afterwards. Additional studies that we use in our office are uroflow and the post-void residual. The uroflow is coming into our office with a comfortably full bladder and actually urinating for us. Our machine will actually evaluate what your flow rate is. Do you have the stream of a 20 or 30-year-old, or do you have the stream of a 90-year-old gentleman with a really large prostate? And we're uncertain on how you're getting around without even a catheter at this point because the flow rate is so small. The post-void residual, again, is that bladder scan to make sure you are emptying your bladder well and you don't have a large amount of urine left over. And that causes the frequent urination, the urgency, and the feeling of incomplete emptying. Pressure flow studies are sometimes used to find out how much pressure is being exerted on your bladder and if there's an appropriate amount of pressure to be able to urinate after a surgery. Cystoscopy and transrectal ultrasound are two procedures that I use frequently, and they're used to evaluate the bladder and the prostate and also figure out what type of surgery you're best suited for. So this is a picture of a cystoscopy on a patient of mine. So I'll point out to you, these are the lateral lobes of the prostate. So these are commonly found in every man with an enlarged prostate due to blockage from the prostate. So you see the lobes coming in, and you actually see that there is indentation. So on this upper portion, the prostate is pushing so hard that it indents on one side of the prostate, and on the other side, it's pushing over here and indenting. So this is blocking this up. On the same individual, you can see this is what's called a median lobe on this picture. This is a third portion of the prostate, the third lobe, the median lobe. This is a portion of the prostate that bulges out in the center and blocks up. I like to describe this to patients as a stop, sort of a flapper valve of the toilet. So if I got this open, this area opened up of the prostate, this would still be blocking things up. This is just a mound of tissue right at the entrance into the bladder. This is very helpful to know for surgical planning what's causing the problem. In addition, I'll look in the bladder, and this is a picture of one of my patients with that permanent damage to the bladder, the trabeculations and the holes, the diverticuli. This is damage that's been happening, again, not over 6 to 12 months that things were worsening for you, where you decided maybe I need to see a urologist. This has been going on for 6 to 10 years leading up to the symptoms that brought you into the office. So moving on, what are the actual treatment options for an enlarged prostate? So we have less invasive treatment options of watchful waiting. We have medications or herbal remedies. We have the prostatic urethral lift. We have thermotherapies. We have lasers and resections of prostates and simple prostatectomies. There are a lot of options that are available now that we didn't have 15, 20 years ago. And there are different treatments that are appropriate for different patients. So what's watchful waiting? Watchful waiting is really doing nothing. You're not having surgery, you're not taking any medications, you're not taking herbal medications. So there's no real side effects from not actually pursuing any treatment. But the disadvantage is the symptoms won't really get better. We need to keep in mind that the prostate is like hair and nails. It keeps growing. It doesn't grow and then stop and then go the other direction on its own. So it will either stay the same size or continue to grow and continue to worsen your symptoms, and more importantly, worsen what your bladder has to do and the effects on your bladder. So medications and herbal remedies. So medications such as common ones such as Flomax or Rapaflo, Avodart, Dutasteride, Cialis daily for BPH. The advantages are there's no surgery and they can provide symptom relief, but they have to be taken every day. These are not medications that you take for 3 to 6 months and then hopefully all your symptoms have gotten better. These are ones that you're probably going to be on lifelong medications for every day. They do have potential side effects. They vary from the dizziness and retrograde ejaculation of Flomax or Rapaflo, and retrograde ejaculation is ejaculating back into your bladder instead of out. That happens in about 20% of patients. They have lowered sexual sex drive or erectile dysfunction that can happen in patients on Avodart or finasteride. There's a potential downstream issues with bladder health. This is one of the things we're really noticing with these medications. Some of these medications will help your symptoms, and patients are very happy with that. And so they go about the next several years until maybe the medications aren't working as well and the symptoms are coming back. But in that time, your bladder is actually probably working harder and harder than it should, even though your symptoms are better. And that's what leads to those findings on cystoscopy that I showed earlier with the trabeculations and diverticuli. And that also leads to those further treatments being less effective. The worst thing is when I see patients that come in after 10 years of increased frequency and urgency and getting up at night, and we do surgery, but they still have this frequency and urgency that they didn't have 10 or 15 years ago. Things are better, but they're not how they were 10 or 15 years ago. And then they ask why. Well, we've alleviated the obstruction. We've helped your bladder out. Things are not going to get worse. But the problem is I couldn't get them as good as I wanted to because there's that permanent bladder damage. And that's the thing that is the hardest in a situation where you got to that patient too late. So we're really striving to get to patients earlier when these problems first arise so that you don't have these problems down the road and that we can also fix them. Herbal remedies, very similar to the medications. The most common one that patients know about is saw palmetto. Most herbal remedies, there isn't a lot of research on them. The FDA doesn't look at. There's a lot of stuff on the internet that you can look at. I don't typically recommend it to patients because my take on it is if it worked as well as the internet said it would, then pharmaceutical companies would buy it for the $20 or $50 it costs you for a bottle. They'd send it to their scientists who would find out what the actual component is. They'd produce it into a medication, and then they would actually get it through the FDA so they can make their millions and millions of dollars. So I think some of them, some of the herbal remedies, take it with a grain of salt. Some do work, but there's not a lot of research on it, so we can't really answer a lot of questions on how well it works or any potential real side effects. Moving on to the prostatic urethral lift. This is the UroLift system. I'm quite familiar with this one. I do a lot of these. I have done more UroLifts than any urologist south of Portland. I'm approaching 200 UroLifts. These can be done in office or under IV sedation. Currently, I am not providing these in the office, but this is what we're working on through Samaritan, and hopefully we'll be able to do this in the near future with all the equipment that we need. Currently, I do this under IV sedation in our surgery center or our main hospital. IV sedation is the sedation that we may all be familiar with over the age of 50 with colonoscopies. So an IV is placed, some propofol is given, you drift off to sleep for about 20 minutes, and the procedure takes me about 15 to 20 minutes to perform. This preserves sexual function. There's no risk of erectile dysfunction in the studies. There's no retrograde ejaculation. That's where the ejaculation goes backwards into the bladder as opposed to out the penis. The symptom relief happens typically pretty quickly. After about 2 to 3 weeks of the recovery time, a lot of patients will already start seeing the symptom relief. Some of them will take about 3 months. However, this is that frequency urgency of urination because this is the bladder not having to work as hard and can start to relax, and some of those muscles can shrink down a little bit, and those symptoms of frequency and urgency can improve over a few months. Typically, you don't need a catheter. Approximately 80% of the patients in the research studies don't need catheters. That's been my experience. About 80 to maybe 90% of my patients do not need any catheters afterwards. There is some discomfort as a disadvantage for 1 to 2 weeks. I've counseled most of my patients that it's about 2 days to about a week, 2 weeks at the very most. And that's frequency, urgency of urination, some painful urination. This is all controlled with over-the-counter pain medication, Tylenol, ibuprofen, and Azo, which is AZO. It's comes in an orange box in the pharmacy for painful urination. You'll have some blood in the urine for maybe a week or so. It's not approved for all types of prostates, but it has been changing over the years. Previously, you needed to have an 80-gram prostate or smaller to have this done. Now it's being used on prostates smaller than 100 grams, but still over 100 other treatment options may be needed. You used to not be able to do this with the median lobe. That's that bulging tissue I showed earlier on that slide in the middle of the prostate. I'm one of the providers here in Oregon that does do this procedure on a median lobe, and I've been doing it for a number of months now, and so with good results. So how does it work? So under IV sedation or local in the office, a scope is put through the urethra. The prostate is compressed with the scope, and a needle is put on the outside of the prostate. One end of the clip is put there, and another end of the clip is put on the inside of the prostatic urethra. So this picture shows 4 clips. There's typically between 4 to 6 clips that are used for this procedure. The nationwide average is about 5 of these UroLift clips. In terms of the actual size, this is the size of the UroLift clip in representation to an actual dime. These things are very small. They don't set off a metal detector. There is some issues with an MRI in terms of certain MRIs. It's not you're not precluded from having an MRI, but the pictures of your prostate after one of these clips. And so we talk all about that, you know, before and afterwards, but not really a significant issue there. So what you can expect is you're given the local anesthetic currently when I do this procedure. As you are in the operating room, you fall asleep for about 20 minutes. I go in, I see the obstruction, I put 4 to 6 clips typically in, open up the channel. I fill up your bladder. You wake up in the recovery room 20 minutes afterwards, and then you urinate, and then you go home. So again, typically no catheter. About 80% or 8 out of 10 patients make it home without a catheter. Some light amount of bleeding afterwards. You have some pelvic discomfort, frequency, urgency, all managed with over-the-counter pain medication. You don't require narcotic pain pills after this procedure. And then symptom improvement as early as 2 weeks, but as we spoke about, some of those bladder issues, the frequency, urgency, getting up at night might take up to about 3 months. And then in the studies when UroLift was first FDA approved, they showed durability at 5 years. Now, I have patients that I did 5+ years ago that are still doing great with this procedure. So the studies just show that at 5 years, there was an 85% success rate at the end of 5 years. In my hands, looking at my patients, I probably would guess I'm about 85 to 90% because of patient selection. Moving on to heat and steam-based therapies. Now the advantages are very similar to the UroLift. These are in-office or sedation procedures, fewer side effects than surgeries. These have been around in different iterations for quite a while. So they have microwave and radio frequency, the Tumpty and the Tuna, that were around 10, 15 years ago. These have largely come out of favor because they just found out they didn't work very well. They were for patients that really couldn't go to the operating room, couldn't tolerate a more difficult procedure and the anesthesia associated. Resume came out in the last several years. It's very similar to UroLift in terms of what you can expect afterwards and before. The biggest disadvantage with Resume compared to UroLift is you will have a catheter. The way these steam procedures, and particularly Resume, works is a needle is injected into your prostate and then steam is placed within the prostate. This causes apoptosis and sloughing of that prostate tissue to open up the channel. Well, this sloughing can cause blockage, and that's why a catheter is put in for a number of days after the procedure to let everything heal up. Symptom relief, you know, typically in about 4 to 6 weeks. The potential for sexual dysfunction hasn't been shown in the Resume procedure, but there were some issues in prior heat and steam-based therapies, which is why I included it in this slide. And again, this is how it works. This isn't exactly how the steam-based procedure works, but this is a good representation of it. It uses steam to destroy the tissue and open the channel up. Moving on to surgery. transurethral section of the prostate, or a TURP. If you have friends, they may have called it the roto-rooter. Green light laser that was out 10, 15 years ago, and laser vaporization. There's also simple prostatectomy, which I won't dive on too much. That's for really big prostates, so 150, 200 gram prostates that really where you have to actually physically take out a portion of the prostate. That is maybe 1 to 2% of patients that come into the office, but most can be treated with the procedures that I'm describing today. The advantage with these procedures is they do maximize your urinary flow. They do make a bigger channel for you. It removes prostate tissue physically. It's durable and has a low retreatment rate. Case in point with the green light, this was used about 10, 15 years ago. I don't know a provider that uses the green light laser anymore. We were using it on smaller prostates, and then the more minimally invasive procedures, the urolift, the resume came, and the green light sort of fell out of favor. So currently, I don't perform the green light anymore, nor do I know anybody in the area of Eugene or Salem that does it. Laser vaporization, very similar to a transurethral section of the prostate. The laser just causes less bleeding, so you can go home. Those are, again, typically used on smaller prostates. I have fallen away from using that because I use the urolift on smaller prostates and bigger prostates, and so found the need to use the laser a lot less so. But with the TURP, which I perform quite often, every other week typically, it's a hospital procedure, so it is a disadvantage in terms of you do have to go under more anesthetic. So as opposed to the 20 minutes of IV propofol, you go under general or regional anesthetic for maybe an hour, maybe an hour and a half, because it's a longer procedure. You're doing a lot more cutting of the prostate. You do have a catheter. It lists here for 1 to 5 days. Typically, our patients keep a catheter in for 1 to 2 days. If they come in with a catheter, then they might keep it in for the weekend and keep it in closer for 5 to 7 days. Erectile problems, the 10%. This is historically speaking. I have not seen this in my patients. The erectile nerves are on the outside of the prostate, and one thing that we found from these minimally invasive procedures is you don't need to make as big of a channel. So I just don't go out as far out to the sides where I could affect erections, because there's nothing worse than a patient that has a really good flow rate and you've destroyed their erections. You fixed something but destroyed something else. So haven't had that as an issue. The loss of ejaculation. This is definitely something that does happen with the resection of the prostate. So when we ejaculate, it goes out of our urethra, out our penis. With these surgeries, there is a 90% chance of retrograde ejaculation. There's nothing dangerous about it, but it means the ejaculation goes back in the bladder and you simply urinate out the ejaculate the next time you urinate. There's a very small percentage of guys that just don't like that feeling. Most guys aren't bothered by it, but it's just something to be aware of. 3% chance of incontinence. Again, luckily, I have not had this happen with my patients, but this is injuring the urethral sphincter, which is right on the other side of the prostate. I've gotten away from this complication, which can happen by leaving a little bit of tissue by that urethral sphincter. And then 7% chance of strictures. This I have caused in my patients because of the scope we use. So the scope we use for this procedure is much bigger than the urolift, the resume, because we're actually taking pieces out of your prostate. So you need a larger scope, and that larger scope can cause irritation to the urethra, the tube you pee out of. It can actually cause a narrowing to happen. So what happens is you actually open up the prostate so a guy can urinate better, and then you cause a narrowing at another portion. And that happens again about 7% of the time. And that's solely based on the equipment that we use for the procedure. So a little bit more invasive, some more complications that can actually happen with it. One thing to note about, the urolift and really like the resume procedure is they don't really burn that many bridges, especially the urolift. The urolift, you can cut out those clips on the inside of the urethra. If you needed to do a resection of the prostate afterwards, you just cut the clips out and it's not a big deal. Here's a picture of how the resection of the prostate works. The scope goes in, again, larger scope, and you actually are cutting into the prostate and opening up this channel to make an open channel. This next picture is actually a picture of one of my patients. So you can see the lateral lobes, the left and right side, blocking things up. And this is a picture afterwards, a nice open big channel that you can urinate from. All of the tissue here, if you can see on your screens, is this whitish tissue. This is prostate tissue. So it started off as pink and red, and you can see little bits over here and little bits on the side over there, but this is all the area that I resected and then cauterized. So I used the loop to make sure there's no bleeding afterwards. So this is all the cut area. So definitely a more invasive procedure, but a bigger opening. Now, I'd like you to compare this to, this is a urolift that I did for a patient with, again, lateral lobes and a median lobe. And this is the picture I showed before. So this was my patient. And then this is the procedure afterwards. Things to keep in mind is, of course, I didn't make as big of an opening as I did on this resection. We'll go back to that. Here's the resection picture. Nice big opening right here. This opening, not as big. You know, all this tissue you could take out, cut all this out. But I would like to point out, he's got a very nice opening here. So he's going to pee very well. And here's the start of the prostate, and here's the bladder back there. So nice open channel, and you can see this pink and redness. This is normal prostate tissue. I didn't have to cut any of this. So definitely less invasive, less recovery from it. Takes about 20 minutes. You spend more time sometimes in your dentist chair getting a tooth taken out. So what's next? So pay attention to your symptoms before your appointment. So every one of these solutions has different risks, they have different benefits, they have different costs, they have different recoveries. And our job is, together with you as a patient, is to find the solution that's right for you. And we can, the goal is to improve your quality of life. And I am available now for any questions that pop up on the screen.
Thank you, Dr. Laciak. There are several questions that have been submitted, so we will do our best to get through as many as possible before we reach the noon hour. The first question is, I had prostate reduction prostate reduction surgery 7 years ago. My symptoms have returned. Does the prostate continue to enlarge after surgery, back to square one?
Yes, that's a very good question. So the prostate, again, as I mentioned earlier, is like hair and nails. It keeps growing. So when you have prostate reduction surgery, that resection of the prostate, that picture I showed you with that nice open channel, that is your new day zero. From there on out, your prostate will grow and get bigger and larger, but at different rates for different individuals. Some individuals will never need to have another procedure performed again. Others will need it. There is nothing short of taking your prostate out, which we typically only do for cancer because of the side effects associated with it. But yeah, so your prostate reduction surgery, your TURP or your green light or your laser vaporization that you likely had, the growth has come back. And now it's a question of coming in and being evaluated and figuring out, do you need another resection of your prostate, or you may just go for the less invasive, depending on how your recovery went the first time around. You may be able to get by with just doing the urolift clips or something less invasive with less of recovery, less of a catheter, and no hospital stay.
Thank you. The next question is oxybutynin effective for men, and if used in combination with tamsulosin? Also, what are the maximum dosages for these two medications?
So yes, they can be. This came out several years ago. There is, and initially there was a lot of pushback because it seemed they work counter to each other. So Flomax or tamsulosin relaxes those lateral lobes. So those areas that I showed you that were coming in and pushing, it relaxes them a little bit, helps with those symptoms and that obstruction. The maximum dose is 0.4 milligrams. Some providers will have you take 2 pills. The research hasn't really shown that 2 pills does actually improve symptoms. Now, anecdotally, I've had patients that have improved with 2 pills, but the research, when they looked at it, you were just spending twice as much. So it's really just that one dose. It can be used with oxybutylene. So oxybutylene works at a whole different mechanism. So what it does is it relaxes the bladder. So that medication is used for frequency, urgency of urination, getting up at night. And they can be used together. Oxybutylene is got an immediate release or an extended release, and up to about 15 milligrams for oxybutylene. Now, you as a patient coming in, if you're coming in with frequency, urgency in a weak stream, and if someone had put you on Flomax to help your stream, which helped a little bit, but then you had frequency, urgency, and getting up at night, I could put you on oxybutylene, and that would help your symptoms, but it wouldn't fix your problem. All I'm doing is masking the fact that you have obstruction, and that obstruction is what caused the frequency, the urgency, the getting up at night. So I'm actually doing some more harm to you because I'm making you feel great with medication, but I'm not fixing your problem. One of the analogies I've given to patients is, you start having this chest pain, and you go in and your primary care doctor says, well, you have high blood pressure and you have chest pain. I wonder if you've got some blockage out of your heart, and they do some tests, and sure enough, you've got blockage out of your heart, but they gave you some medication to bring down your blood pressure, and your blood pressure goes down and your chest pain goes away, and you're happy because your symptoms are better. But every single day, as your blood pumps out of your heart, it's working harder against that obstruction, and those symptoms may come back, but worse, your heart's probably being damaged, just like your bladder gets damaged. In the sidelines. You're doing great, but the rest of you really isn't. You just don't realize that until down the road when symptoms come back, and then we can't necessarily get them all better. So medications like oxybutylene, I tend to reserve on guys with large prostates because I can also relax the bladder so much I can put them into retention where they can't pee and then they have to get a catheter. I have used it after I've done surgery on a patient if they don't recover from the frequency urgency soon enough, because their symptoms were so terrible that they've gotten a little bit better, but they're still miserable. Once I have alleviated the obstruction, so the obstruction is gone from that, and their bladder doesn't have to work as hard, then I'll sometimes put them on this medication for a short term, maybe 3 months, maybe 6 months, to relax their bladder, to let the bladder actually have that time to recover and for them to get the symptom relief, and then take them off at 3 months and see if they even needed it anymore.
Thank you. Next question. You mentioned sleep apnea. Would you talk about this relationship again? And does BPH make sleep apnea worse?
So, yes and no, it makes it worse, and I'll get back to that. But I have patients come in, and through the medical history, we find out that they're getting up a lot at night. But during the day, they don't have any frequency, they don't have any urgency, they don't have all the rest of the symptoms, but they have very thick necks. Maybe they're overweight. We start asking them about their medical history at night. Well, you're only having symptoms at night of waking up 5-6 times a night. Do you snore a lot? Do you have a partner at home that hears you stop breathing? So we've actually diagnosed sleep apnea a number of times in our office, and by diagnosed, we can't really diagnose. We send you to the sleep study experts who then diagnose you with sleep apnea, but we put you on that path. And it turns out that you don't really have BPH symptoms. You have sleep apnea, and once you get the CPAP, the sleep apnea is under control, and then you're not waking up as to urinate because your sleep apnea is controlled. Now, if you continue to wake up with controlled sleep apnea, then you may have BPH symptoms. In terms of does BPH make sleep apnea worse, it makes it worse in terms of if you're waking up 5 or 6 times a night because of your sleep apnea and you've got BPH that's making you wake up in addition to that, then you're that kind of patient that's getting no sleep at night and you're miserable because you're completely exhausted. So that's how BPH could make it worse if they're existing together. But those are things that we try to figure out and glean from your visit. Are there other things that are causing your symptoms, or is this the enlarged prostate and we need to go down the evaluation route for an enlarged prostate?
Thank you. So this individual asks, they have a couple of questions. Are there any dietary or exercises changes that can help, such as does frequency of sexual activity, such as ejaculation, affect prostate health?
So for those three conditions I mentioned earlier, the prostatitis, the prostate cancer, and the enlarged prostate. Prostatitis is an inflammation of the prostate. And if you get diagnosed with that, a tender prostate, some weird frequency, urgency, pain symptoms, and you get a prostatitis, studies have shown that more frequent ejaculation does help, because part of the theory is that the ejaculatory ducts get blocked up with seminal fluid because it doesn't get out of you, and that may be what causes that inflammation from the blockage of fluids. So more frequent ejaculation may help with prostatitis if you get diagnosed with it. Preventative, I don't know if they've really ever done a study to find out that if men that ejaculate this X amount of time are less likely to develop a prostatitis. Dietary changes for it. I will say that obesity can cause more frequency and urgency. We've found this in our male and female population. Think about this. Pregnant females in their eighth month, they have this fetus in there that's large and pushing down on their bladder, this extra weight. So they have to pee all the time. That same thing, that extra abdominal pressure of being obese can push down on the bladder and cause more frequency and urgency. We see this in our female patients that don't have a prostate, and our male patients obviously equally, they have a prostate, but also their weight has to do with that frequency and urgency too. So, you know, weight loss definitely could help to a certain extent. Now, there is no amount of weight loss that can help your prostate shrink down, but it can affect that extra frequency and urgency. Dietary wise, they've had different things about selenium and tomatoes to help prostate health. I think just sort of a healthy lifestyle. They haven't really found the sort of that magic cure pill of if you eat this and you don't eat that, this will ward off your prostate cancer and BPH, unfortunately.
Thank you. How well does urolift procedure relieve sudden urgency symptoms, and what is the expectancy that you can anticipate that it will be effective?
So how quickly? I've seen it. We typically will, for our practice that we've been doing it like this for, several, 5+ years, 5-6 years I've been doing urolift. We'll typically see a patient back about 3 to 4 weeks later, and at that 3 or 4 week mark, a large number of patients will have improvement already in their frequency and urgency of urination. Again, some of them take longer, and the ones that do the best are the ones that have not had symptoms for as long, because the longer you have symptoms, the more damage to your bladder, and therefore it may take longer for those symptoms to improve with time. Those are the ones that might be closer to that 3 months, maybe 6 months. But the ones that got to us early with these symptoms and started developing the urgency and frequency, they get better faster. Sudden urgency and frequency, we'd have to also make sure that there's nothing else going on in our office, and they have already been taken care of by your primary care. We want to make sure you don't have a urinary tract infection. We want to make sure you don't have a prostatitis, which can cause sudden urgency and frequency. So these are all the things that happen in sort of the evaluation process to make sure that this is an enlarged prostate. Did I answer all those questions there? I think I did.
Yes, thank you. So we are at about time, so I'm going to wrap 2 questions into one. Can you touch on what type of insurance covers the urolift procedure? And if somebody has symptoms, what's the best way to contact the office?
Sure. I am a very happy urologist, and it's because I don't deal with insurance with a non-for-profit, so I don't have that much information on it. But almost we have, because I've been doing so many urolifts, I do have the experience in the fact that we do not get very many denials back. I cannot remember the last time we had a denial. And because we document your symptoms, we perform a cystoscopy, a transrectal ultrasound. A lot of these things are required by insurance companies. An AUA symptom score required by a lot of insurance companies, a uroflow and a PVR. So we do all the we're very good within our office of doing all our checks and balances. And I can't remember the last insurance company that's denied a urolift in our office. So I think the majority of I think all of them, it used to be Medicare only, and then it was tough, but this was years and years ago. And now I think, again, I think we're in good shape that we just don't get any more denials for this. They've actually, UroLift and Resume both made it into the AUA guidelines, talking about treatment options, and that went a long way with insurance companies. Because that's sort of our gospel and Bible and the American Urological Association in our guidelines. In terms of longevity, again, I'd say 85–90% in the studies that came out. It was about 85% of patients had lasting results. I would say in my patients, I'd say 85, probably closer to 90%. So I think I'm better than the studies have shown.
Thank you. And really quickly, if somebody is experiencing symptoms, what is the best way to contact the office?
So best way is to, you can go through your primary care, but if you wanted to, you can, if you're having symptoms, you can give our office here at Samaritan Urology a call and let them know that you attended this virtual seminar and say, I'm having urinary problems and would like to be evaluated. And then my office can check to make sure, because some insurance do require a referral to our office, such as the VA and some private insurances. But if not, we can get you in and start the evaluation process for you.
Wonderful. Thank you, Dr. Laciak, and thank you everyone again for joining us today. The survey link has been published in the Q&A portion. If you could please take a moment to complete that. Also, remember to watch for a follow-up email that will include a link to the recording. Thank you very much and have a great day.
Thank you, everyone.